Students, good morning. This is the lecture for Monday, March 23rd, Chapter 16, Drugs Affecting the Endocrine System. We're going to talk about thyroid and osteoporosis medications, specifically this morning. So follow along in your book, Chapter 16 in Vygotsky. That is your book on pharmacology. Some of your objectives, we're going to talk about endocrine not in specific detail, and talk a lot about teaching and some side effects. We'll talk about the adrenal glands, a little bit about the endocrine system, which you guys have already learned from Mr. Miller, and some about hormones for birth control and so forth. Okay, so the first slide is going to be, we're going to be talking about hormones and how they work. Hormones go into your bloodstream. Remember, they're different than a medication. They go into your bloodstream. And this is all in our biofeedback mechanisms in the body that I've talked about many times. There are glands, pituitary, and other glands that secrete hormones that stimulate other glands to work. So the biofeedback is always happening from one gland to another. A hormone can change the action of another gland, or it can target a tissue. For example, the sex hormones may target the genital area, those tissues. So just remember, they work on another gland or they target a tissue. There are natural and synthetic preparations. Synthetic are the ones that are made and distributed by prescription. And as I said, they're used to replace or increase or sometimes stop the production of natural chemicals in the body. When the body is lacking a basic hormone, glandularly, perhaps in the pituitary, a message is sent and then to the target tissue, and it tells the tissue to secrete the hormone. When a person has surgery to remove a gland, let's say a thyroid, then they will require HRT. That stands for hormone replacement therapy. We may be using the words, the acronym HRT today. HRT is also estrogen, birth control. Those things are considered to be HRT. Also, insulin is secreted to receptor sites, and when there's enough insulin, for example, the beta cells don't produce anymore. When more insulin is needed, the beta cells produce extra insulin. This can have an effect on type 2 diabetes. You remember we've talked about pancreatic fatigue being a reason for type 2 diabetes. So always remembering that the body senses changes and it sends out signals to tissues to change the blood level, sometimes to block production, sometimes to increase production. That's an overview. Okay, continuing on. The endocrine system, as I said, is a coordination of body systems. Pituitary, the thyroid, the parathyroid, the adrenals, pancreas, testes, ovaries, and even the placenta can send signals and receive signals as target tissue. Remember, there may be people who have, as I said, a surgery. Perhaps they have a tumor that comes into play often. Perhaps they have had part of the reproductive system removed, such as perhaps the uterus or ovaries. So these things will affect the body. We may then, for the patient's health and well-being, use hormone replacement therapy to give drugs that are performing like the natural hormones that may be needed. Oftentimes they're for a short time, for example, menopause, or permanently for those who, for example, may have a thyroid surgery. Once a thyroid is removed, there's a lifelong need for synthetic thyroid hormone. And diabetes management, remember insulin is a hormone. So those persons, especially type 1 diabetics and insulin-dependent type 2, may need management for their life with insulin, which, as I said, is a hormone. Okay, we're going to start with thyroids. Now remember, there are hypothyroid persons and hyperthyroid persons. We treat them both slightly differently, and you will see, especially if you work in family practice or in an urgent care clinic, that we will have a lot of regulation of thyroid hormones synthetically by physicians and providers. The thyroid action is that it sets the metabolic rate. And the metabolic rate, if you will look here on this slide, you'll see that, importantly, the thyroid increases tissue oxygenation, okay? Oxygen consumption, body temperature is a really important one, heart and respiratory rate. I hope you're thinking along the lines that if you don't have enough thyroid, these things could be affected. If you have too much, these things can be affected. Protein metabolism and development of skeletal system, which is bones. So you can see here that we have a very careful balance in our body for our metabolic rate, and the thyroid is really in charge of the metabolic rate in the body. We replace thyroid hormone for several conditions that we will talk about, but remember metabolism. So the reason I'm emphasizing that is someone who's hypothyroid will have a low metabolic rate. Someone who's hyperthyroid will have a high metabolic rate. I want you to use your critical thinking to think of a person with low metabolism, would be heavier, move slower, have less energy, have more weakness, have a lower heart rate, and so forth. Now, a person who's hyperthyroid then may have, by the same token, high heart rate, increased metabolism, loss of weight, changes in their hair, breathing patterns, and so forth. So just keep that in mind, and that will help you out a lot. With thyroid, the thyroid itself produces critical hormones in the body, and these are called T4 and T3. They have really long names, but for now let's call them T4 and T3. And I want you to look on box 16.1. It's on page 293. These symptoms I just touched on. I'm not going to go over in detail for the purposes of not having you listen to each symptom, but they go along with what I was just saying. So really review those because you're going to need to know those for the test. So hypo and hyperthyroid we're going to talk about, and we will have to supplement or give a medication that will control the overactive thyroid. So keep that in mind. Okay, moving on to the next slide. Again, this kind of talks about what I was saying. Look here and you'll see that an adverse reaction could also be if we've given a person too much thyroid medication. Dysrhythmias, hypertension, tachycardia, these things all go along with someone who's hyperthyroid. They're nervous, they can't sleep, they lose weight, they have rashes, they become hyperglycemic, and so you can see that this could be a dangerous situation. And there are situations where persons can have dangerous thyroid situations. These can show up in the ER with, tachycardia and tremors and massive headache. So always doing a good history of what medications persons are on will help you a lot as a nurse. In the family practice clinics, you will know a lot about what patients are on. So that helps a lot. Drug interactions do happen always with any medication. and we have to make sure that we know what the patient is on for sure. The specific drug interaction I wanted to talk about was anticoagulants. So remember, we always have problems with some medications and Coumadin, but thyroid medicines and Coumadin sort of increase each other's action. So therefore, you might have a person who has bleeding, bruising, and that might be their response for taking thyroid medicine, especially if their thyroid gets too high. That might be an issue when they are on Coumadin. All right, let's move on to the next slide. Okay, nursing implications in patient teaching. This is a big issue, of course. And one of the things I want to tell you right off the bat is that our patients will have to need a really good assessment to make sure that we know, especially after we put them on the medicine. Let me tell you what I'm trying to say here. When we put someone on a medicine who, let's say, is hypothyroid, and they're diagnosed and we start the drug low, the drug dose is increased, kind of like we have done in the opposite fashion with the steroids, if you remember. We taper those. We increase these slowly every 2 to 3 weeks until the patient has normal T3 and T4 levels and signs of normal metabolism. That would be their symptoms that they presented with are much better. So they are feeling better and not so nervous or not so sluggish, one of the two. With Synthroid, patients' heart rates and blood pressure are monitored because remember, we're increasing the thyroid hormone, which means we're increasing the metabolism, which means we could be giving them tachycardia. So a very thorough set of vital signs when they come in for sure. Synthroid is given in the morning before any food is absorbed. Food in the gut will decrease the absorption of thyroid medications, and that is the opposite of what we want to do. We want the person to be very stable, taking it before breakfast, very early, 2 to 3 hours if possible, before there's food in the gut, so that we can really regulate their thyroid. We like to teach patients not to skip them. It's very important for their metabolic rate to stay steady. Remember, their thyroid is not working if we're giving them thyroid medication, Synthroid, so their metabolic rate will be going up and down a lot if we're not taking it every day. And again, they should never stop it abruptly. You can imagine what will happen if they stop it abruptly. So administration has to do with not skipping and not taking it with food in the morning and not for sure stopping it abruptly. As a side note, you won't need to know this for this test, but women who are pregnant may need higher doses. We certainly don't take pregnant women off of it if they have no thyroid, because this is setting their metabolic rate, remember. And one really important note that you'll see, and it's also in the book in quite a few different places, we make sure we educate our patients that you don't substitute. So there are different kinds like levothyroxine, Levoxyl, and then there's liothyroxine. So we don't ever recommend them switching back and forth. They're dosed completely differently. Some of these are dosed in the micrograms, and some are dosed in milligrams. So it's very, very important that they not switch back and forth between different synthetic thyroid hormones is what I'm trying to make sure that you guys are understanding. Okay, now moving on. I just want to make sure that I am making it clear that this is about supplementing with thyroid hormones for people who are hypothyroid, and this is called HRT. Remember, that's hormone replacement therapy. So we started out with hypothyroid. We will move on to hyperthyroid on the next slide. Okay, students, as promised, antithyroid. Now, someone who has a thyroid issue, sometimes it's usually Graves' disease is a disease that is sort of a disease of the thyroid. And these people are hyperthyroid. We also call it overactive. You might hear it called other words, but hyperthyroid means that we need to block the thyroid. Now, most of the time, I will tell you this is done with surgery, but in the meantime, we will try to, let's say, stabilize or reach hemostasis on the patient with medications that might block the thyroid. So there is a main one, and we call it PTU. So write that down, but you can look it up on page 294, and it's called propylthiouracil, but we commonly call it PTU, and it is sort of a blocking agent for the thyroid, and it keeps the thyroid from being too overactive. You can imagine if the thyroid is at all times secreting hormone, it can get enlarged. It can cause something we call a goiter, which is an enlargement in the neck where the thyroid is. Again, these medications interact with Coumadin, so a person can become anticoagulated too much, and it interacts with the anticoagulants. It is somewhat difficult on the liver, so we are watching our patients to make sure that they don't show signs of jaundice. Severe hyperthyroidism, so a person who has severe hyperthyroidism can have life-threatening hypertension, heart failure, and seizures. And this is called a thyroid storm. It's a very scary situation. The person will usually be in the emergency room. And we definitely have to get the thyroid hormone decreased, of course. We oftentimes do this with radioactive iodine, radiation to sort of kill off the thyroid cells. And then we may end up using antithyroid drugs in the short term, but usually thyroid surgery for the long term is our goal. Okay, toxic, the thyroid really has a lot to do with the heart rate and the nervous system, as I said. So that's, heart rate, cardiac system and nervous system. So heart rate and, as I said, like tremors and seizures. So we want to really make sure that we're regulating this. We do see some immunosuppression with these drugs because they decrease the immune response a bit. So we have to watch for infection, watch for their white cells, and make sure that we're doing a thorough assessment. For LPNs, especially working in clinics, you're going to make sure that your patients are taking them at their same time every day, as I talked about, that they are not missing doses. And for the PTU specifically, we have to watch liver function. Those are usually short term. I really want you to remember here that we're watching for bone marrow suppression, which would be low white cells, anticoagulation if they're on warfarin and Coumadin, and for the PTU, especially for the liver function and perhaps jaundice. Okay, we're moving on to the adrenal glands. The adrenal glands are two little glands that are located on top of your kidneys. Now, they aren't part of the kidney, but they sit on top of the kidney, sort of on the outer cortex. They're responsible for corticosteroids and aldosterone. And we're not going to go into a huge explanation of that, but think of those two things: corticosteroids, which is glucocorticoids, and aldosterone is what controls sodium and water. So if we have issues with the adrenal glands, we'll have issues with sodium and water, which could be either dehydration or over fluid volume excess, or it could be sodium imbalances, which will mimic, water issues. And then with steroids, obviously we've talked about those are the stress hormones. They can increase your blood sugar and cause sort of problems with your cortisol, which is the stress hormone. Adrenal glands, when they're hypofunctioning, a person will have hypoglycemia and wasting of salt. The opposite is true then for a person who has overactive adrenal glands. Then we would have the aldosterone and cortisol in the opposite direction. So hyper would mean higher levels, hypo would mean lower levels. You'll learn a lot about Addison's disease and PN3, as well as Cushing syndrome. Both of these go together, but at this level, we want you to understand the safe administration of the medications. When we have high glucocorticoids, the person has high blood sugar. When we have a high adrenal function, they might have a high sodium in water, which would mean edema, okay? Remember that our glucocorticoids are the same as steroids, so that means that steroids, if they're not in the right balance in the body, can cause high blood sugar or low blood sugar in that person. Also, remember, steroids are responsible for inflammation, right? So we give steroids to reduce inflammation and reduce allergic and immune responses and treat other diseases. So very carefully, we have to make sure that our adrenals are functioning because it has to do with water balance, sodium balance, and sugar balance in the body, okay? We will replace, if a person has adrenal gland insufficiency, and we may have to block if a person has overactive adrenals. Normally, overactive adrenals are associated with a tumor, and those tumors will be removed. Same as we talked about with thyroid, okay? So we may have to replace them so the glucocorticoids are correct. We may have to replace them if the sodium and aldosterone need to be replaced. Okay, let's be clear here. If we're trying to replace for adrenal insufficiency, we would give corticosteroids, especially prednisone, S-O-N-E, prednisone. If we're trying to replace the aldosterone action, there is a medication called Florinef. It's fludrocortisone, and that may be used. So we're just replacing those two hormones that are lacking in the adrenal gland. Now we're going to go on to hyperfunction. This was hypofunction. Okay. I already talked a lot about Coumadin and insulin. So if we have a need to increase the glucocorticoids, that'll increase the blood sugar, and that might affect insulin. If we have Coumadin on board, then we may need to watch for bleeding. Okay. Now, we're still on hypofunction, okay? When we are thinking about hypofunction and teaching, we're always telling our patients to monitor themselves frequently because of the water and sodium. So if we're giving someone the aldosterone hormone for sodium and water, they can have heart failure because of too much sodium. And which means, the water follows salt. So we want them to weigh themselves daily. Make sure that they let us know if they are gaining weight. Remember how to do the weight gain. And of course, we should we know that a person who doesn't have enough adrenals does not have enough stress hormone, that's cortisol, then we might have to increase those doses in times of stress. Not just psychological stress, sometimes physiologic stress. Don't stop them abruptly, of course. Watch the storage. Again, dosage and scheduling should be very strict. I do want to tell you about a medication called Korlim. It's mifepristone. It is given for people who have hyperfunction, Oh, let's scratch that, students. We'll talk about that in a moment. Scratch that. I'm really sorry. Okay, so weigh daily is what I was saying there. And there's a lot here on this slide, but these patients need to take the medication because their adrenal glands are not working properly. And all we have to remember is that they have corticosteroid function, the adrenals, and aldosterone function. Okay. Now, here's hyperfunction. So let me continue on hyperfunction. Oftentimes this, as I said, is a tumor. And oftentimes we may be looking for surgery, but these persons have too much aldosterone, too much steroid, and we oftentimes give this medication I was going to talk about called Korlym, which is mifepristone. And why I'm talking about that is that this can cause loss of pregnancy, sort of spontaneously abort a fetus. So really we have to be very careful and make sure that women are using really reliable birth control while they're on this until the surgery perhaps can happen. It can cause birth defects as well. So we have to be very careful about that. And that's one of the big teaching points about that one for sure. The teaching point also is that patients shouldn't miss doses. And we have to teach them about hypo and hyperglycemia on these drugs with an adrenal issue. And also cravings of salt and edema. So we're just watching sodium, water, and blood sugar with these. Okay, now we're going to move on to the sex hormones. So just think of this as estrogen, progesterone, maybe testosterone. That will help you with those categories. The male is testosterone. Those are called androgenic hormones or androgens. So keep in mind that the male hormones are androgens and the females are estrogen, progesterone. So this happens at puberty in the human body. Puberty indicates that there is an increase of the sex hormones in production. Changes happen in the body. Estrogen is the main female hormone and testosterone for males. So that is the time when the body is starting in production of sex hormones, and the body is changing. In females, we're going to talk about on the next slide, the two hormones kind of related, and in males it's going to be mainly testosterone. Rising estrogen levels are going to make it a possibility for the female to get pregnant. Rising testosterone levels for the male to impregnate a female. Okay, we talked about estrogens and progesterones. There are a couple of hormones that are released from the pituitary gland. One is called FSH, follicle stimulating hormone. This is on page 299. And the other one is called luteinizing hormone. Really, what I want you to understand is that the pituitary tells the body to, the pituitary secretes follicle stimulating hormone. This tells the body to secrete more estrogen, and it tells the ovary to make an egg. Okay, their eggs are there, but it will be to release the egg. And the uterine lining is now growing and thickening so that it is available for the egg to be passed through the uterus and fertilized. Now, luteinizing hormone also helps the egg then to be secreted by the ovary into the fallopian tube, and so both of these trigger possible pregnancy, of course. So this is all in the pituitary gland, which is regulating the target tissue, being the ovary and perhaps the uterus. If the body does not have a fertilization of the egg that happens at that time by sperm, then conception will not happen, and then the lining is released, and that is the menstruation monthly. So that's the feedback loop and sort of how it happens. Now, when we have a pregnancy, then these hormones are secreted to support the pregnancy, and it is an opposite feedback mechanism where the body is told that there is a fertilized egg, and then it changes the levels of estrogen and progesterone. So then estrogen doesn't need to make an egg, or the body doesn't need to make an egg. There's a fertilized egg. So then we come to then have more progesterone in the body, which helps the uterus to support the fetus. In menopause, this is where we'll have a lot action happening with our body. When we have menopause, we'll have some changes, and we want to make sure that we're educating our patients that they understand there's a decrease in estrogen. No ovulation then happens. At this point in time, I want you guys to make a note that the rate of osteoporosis is highly increased, and then we do HRT to supplement the body because we're trying to decrease abnormal bleeding. One of the hugest teaching points here is that we want to make sure that we tell our patients not to smoke with these pills, whether they're birth control or HRT, because there is a high incidence of clots and strokes with birth control or hormone replacement therapy in females, and smoking. Also, these cancers can increase, these medications can increase the risk of certain breast cancers if they're used over the long term. Okay, so the main point about hormone replacement therapy is it increases the risk of blood clots, especially in the face of smoking. And we want to make sure that we're teaching our patients not to smoke while they're on hormone replacement therapy, or especially while they're on the birth control pill. We use these progestins or birth control for contraception, of course, to control excessive uterine bleeding that might happen in menopause. Dysmenorrhea, which, if you guys remember, is painful cramping. Oftentimes they'll put a female on birth control to control the cramping and the PMS that females will get, and to decrease the pain of endometriosis. So those females certainly should not be smoking. If they've had a previous blood clot, it's contraindicated for them to be on hormone replacement therapy or contraception because of the high risk of stroke, even in younger women. There's a lot of different brand names of birth control pills, so I'm not going to go over those today. If you look on page 302 in the table there, 16.3, you don't need to memorize those for any of the testing. There really isn't a lot of memorization. We know that when we give estrogen, progesterone combination medications, we are giving hormone replacement therapy. Sometimes, remember, it's for perimenopause or menopause, and sometimes it's for birth control. In any case, it's to control the secretion of estrogen, progesterone in the body. We have found that women who are on hormone replacement therapy who have high risk of heart attacks or heart disease, or perhaps have had a heart attack before, will usually not be given hormone replacement therapy for menopause. Also, those women who may have a history of estrogen-fed breast tumor. If you can imagine, if a woman has a breast tumor that has estrogen markers, then we're giving them estrogen for control of symptoms that might increase the size of the tumor or their risk. So those are definite contraindications. You also have to watch, make sure your patients are telling you about over-the-counter medications that they're taking, antibiotics, because that could make the birth control pill or the hormone replacement therapy not as effective. So that's a pretty well-known fact that we make sure that there's another form of birth control when females are taking antibiotics. Okay, we've been talking about this already. Some of them will prevent ovulation. Sometimes they're used for contraception, sometimes for deficiencies. So just remember, we're giving females who are menopausal kind of the same medications we give for contraception, but they're in different measurements and a different medication, but the same hormones, just in different fractions within the medication. What I want to make sure you guys know is that at menopause, there is a acceleration of osteoporosis. The patient needs to be on calcium and vitamin D, and of course doing weight-bearing exercises. But we do give them hormone replacement to modify their night hot flashes and other symptoms that they get that affect their quality of life during the time that they're in the menopausal years. We again talk to them about blood clots and thrombi or emboli and heart attack and stroke. So those patients really are oftentimes not offered replacement therapy if they're not able to stop that habit. Okay, we're almost there. We're on androgens, which again, remember, is testosterone. It is what is in charge of the development of secondary sex characteristics in males. We do have diseases of hypogonadism, which means the penis or the testicles do not develop. Low levels of pituitary that's not telling the body to release growth hormone. This results in dwarfism and poor sperm production. Also, perhaps the testicles don't descend, and some males just have an androgen deficiency. So we will give these medications for supplements. So this is hormone replacement therapy, basically for males when we give the male testosterone. A lot of males in this country are on testosterone now because of maybe muscle wasting, fatigue, because testosterone levels do go down over time, especially as males age. Anabolic steroids are synthetic, and you guys have probably heard of roid rage, but what we're talking about is steroids. When we give anabolic steroids that are synthetic, they are to help maintain the male characteristics. Some males will have loss of body hair, impotence, and so we give these medications to decrease those symptoms. Remember, we can have people that will abuse these, males that will abuse them when they're bodybuilding or trying to build extra muscle. And unfortunately, when they take these synthetic steroids or anabolic steroids away, then they have muscle wasting, again, hypogonadism, gynecomastia can happen, which is breast development in males. And so when males go off of these, or when they're taking them in amounts that are not being modified by the physician or monitored by the physician, then we can have these problems for sure. They can have edema, acne, hirsutism is hair growing on different parts of the body. Interestingly enough, with these, what I've always found interesting is the males lose all the hair on their head, but they grow hair other places. So male pattern baldness of the scalp is a different genetic marker in the DNA, so they will lose their body hair or gain body hair, one of the two. Okay, again, just like the female hormones, they increase anticoagulant effects, and when they're used with other corticosteroids, which could be something like prednisone, then they can increase edema and water retention. So we have to be very careful to do a history, making sure we know what our male patients are on, and if they're taking some kind of a steroid that they've gotten somewhere on the internet, likely. We want to make sure they're not decreasing or increasing doses quickly and not changing abruptly. Okay, these can be administered by patch, sublingual, injection, in most forms, of course IV, but that'd be very rare. And we want to make sure that if males have jaundice, gynecomastia, issues with their genital area, that they report those quickly, because that could be just an imbalance in the testosterone. We do blood levels to make sure that males are at the right level. Okay, we're moving on. The last category here is the osteoporosis. Remember, in menopause, we go into osteoporosis very quickly. Females do. So we have calcium and vitamin D. Smoking should be decreased if we're using HRT. Bone loss happens quickly here. We need to increase their weight-bearing exercise. Spinal shortening happens, increase of fractures. So these are the times when we want to make sure women are on HRT so that this doesn't happen. And when they come off of HRT, that we're watching for the calcium and vitamin D and making sure that they understand about weight-bearing exercise. We have, as I said here, destroying of bone cells. We have what happens in the female body often is that there is an increase of osteoclasts. You see here osteoclasts. Those destroy bone. And then osteoblasts are new bone cells, and those are suppressed in menopause. So that is why women have more fractures and more osteoporosis, because of the imbalance of osteoblasts and osteoclasts. We're going to talk about the medications here on the next slide. But I want to talk about the bisphosphonates. That's Fosamax and Boniva. So they all end with ATE. I call them the ATEs, but the ATEs are the bisphosphonates. And there's one specific teaching point, and that is that they're taken first thing in the morning on an empty stomach, and that the patient must remain upright for 30 minutes to an hour. We encourage either this is the time where they walk, do their morning walk, or that they don't lie back down. And this is vital for the esophagus and the stomach so that they don't have problems there. If they work correctly, they help the blood to move, the calcium to move back into the bone and not to be moved out into the blood. The other big thing about Fosamax and Boniva is, listen to this word and write it out. It is osteonecrosis of the jaw. Osteo meaning bone, necrosis meaning death. So one of the large side effects from Fosamax and Boniva is osteonecrosis of the jaw. That means that the jaw starts to sort of literally kind of crumble. Dental, pulling a tooth could mean that there's a fracture in the jaw. So they need to let their dentist know, but we really have them watch that, and usually the dentists are the ones that will see it on dental x-rays, and then that would be a contraindication for that female, and they would not be taking that medication. Remember, two of the main drugs for osteoporosis are vitamin D and calcium, so keep those in your understanding in your repertoire. The Fosamax and Boniva are for those who have large bone loss, and then we also give, for the next slide, we're also going to give estrogens. Remember, when a woman goes into menopause, they lose the estrogen. If we replace the estrogen, then the bone loss doesn't happen quite as quickly. And so those might be in the form of a cream, in the form of a pill, in the form of a patch. There are many different names given to them, trade names, but they help promote calcium absorption back into the bone. They decrease the rate of osteoporosis. So importantly, these are used for menopause. Okay, we're on the last slide here. There's a drug called Prolia, and it's not been out that long. It's given once every 6 months subcutaneously to help. It binds the osteoclasts so that the osteoclasts do not get to the bone, and then the bone does not break down as much. The bone tissue can be more mature, and there's loss of, there is decreased bone loss and increased bone density and strength. It's only used for severe cases because it causes, in many patients, the jaw osteonecrosis that we talked about. So in severe cases of bone loss, it's used. Now, I will tell you some of these drugs, interestingly enough, you don't need to know this for the testing, is we give them for bone cancer because we don't want the bones to leach out into the blood and for the person to lose all of their bone mass. These people are usually either terminal or they have, bone cancer with metastasis. And this might just help the symptoms, and it might help them preserve some bone mass prior to, the cancer medications that we're going to give. So we sometimes will use it for that. Okay, students, that is the last of this chapter, and this information, make sure you took notes on it. A lot of this will be on the test, and we will review it in the next study session.